Hello everyone and welcome to today's lecture. My name is Stanley and I'm an advanced practitioner sonographer working with the NHS England. Today I'll be guiding you through an essential topic in prenatal ultrasound, Nuchal translucency measurements and combined screening tests in the first trimester. This section is designed for trainee sonographers, experienced clinicians and doctors involved in antenatal care. We'll explore how this screening plays a pivotal role in the early detection of chromosomal conditions such as Down syndrome, which is trisomy 21, Edwards syndrome, and Patau syndrome, which is trisomy 18 and trisomy 13, respectively. Everything we'll discuss here is going to be aligned with the guidance from the British Medical Ultrasound Society, BMUS, the NHS Fetal Anomaly Screening Programme, FASP, and UK National Screening Committee recommendation. So let's begin. So introduction to the combined screening. So combined screening is highly structured, evidence-based method of assessing the risks of certain chromosomal abnormalities in early pregnancy. It integrates maternal factors and biochemical results with the ultrasound measurement of the NT, and that's at the back of the baby's neck. So combined screening brings together three pillars: the mother's age-related risk, two biochemical markers, which is also known as the beta HCG and the PAP-A, and the ultrasound-derived NT measurements. This triad offers a robust risk assessment that far exceeds the accuracy of age-based risks alone. This screening is optimally carried out between 11 weeks and 2 days, up to 14 weeks and 1 day gestation, which corresponds to a crown rump length of 45 millimeters to 84 millimeters. At this gestation, subtle physiological variations in the fetus can be visualized effectively with ultrasound, while biochemical markers remain valid and clinically meaningful. So, Nuchal translucency refers to the fluid filled sonolucent area at the back of the baby's neck, visualized in a true sagittal section on ultrasound. This space reflects physiological accumulation of lymphatic fluid, which when increased may correlate with a range of fetal abnormalities, particularly chromosomal ones. A thicker NT is statistically associated with Down syndrome, but also Edwards and Patau syndromes, congenital heart defects, various genetic syndromes such as Noonan or Turner's syndrome. Accurate NT measurement is dependent on stringent criteria. The gestational age must be within 11 weeks 2 days to 14 weeks and 1 day. The CRL must fall in between 45 to 84 millimeters. The fetus must be in a neutral position, which we're going to see in the next couple of slides. So it shouldn't be flexed and it shouldn't be hyperflexed or extended or hyperextended. The magnification should ensure the head and the upper thorax fill at least 75% of the screen. So the reason for doing this is to make sure you're reducing the measurement error. So next is the amniotic membrane must be distinguishable from the fetal neck. So remember, if the fetus is lying tightly, so the back is tightly in contact with the amnion, you won't be able to differentiate that. So make sure you're not measuring the amnion. You'll see that in the next couple of slides as well. So one of the things we'll do is place calipers on the inner to inner border of the NT space, not inner to outer or outer to outer, inner to inner. And most importantly, take the largest of 3 reproducible measurements. Any deviation from all of these I've mentioned, can significantly impact the risk calculation, leading to either false reassurance, or unnecessary anxiety. That's why consistent, standardized training is very critical. So looking at these 9 images, we're going to start from the bottom right. So the bottom right image, the baby is a bit stretched out. So the baby is arching the back. That is not standard for measuring the NT. So that is going to give a larger NT because you can see the angle there. The angle is a bit more extended. So moving on to the next one, to the left is a similar thing, but this looks a bit more arched, and you're not gonna get the right measurement. It's gonna give like a false positive result. And the next one is also similar. So all of these are similar. So ideally, remember, the baby needs to lay in a neutral position. We'll get to that at the last bit of this presentation as well. So all of these images you can see, all of these sonograms you can see on the screen, apart from the one in the top left corner, all of the other ones do not meet the criteria. So there's a very strict rule to this. So I'm going to talk you through it in the next slide. So, but if you look at the top left image rather, you can see that the fetus is in a neutral position. What do I mean by neutral position? It's flat on its back, and it's not angulated, head up or head down, or it's not arched. So there is no arch on the spine. So it's looking nice and in neutral position there. So you can see the tip of the nose is above the tummy, and you can see the mesencephalon there, and you can see the part of the baby's brain and all of that stuff. So you can also see the mandible, rectangular mandible, and you can see a space in between the chin and the neck. So it's a bit more neutral in that position. So you're going to see a proper image in the next slide. So this is the exact image of what I've been talking about. So you can get a CRL measurement from this sonogram, and you can also zoom this in to also get an NT measurement. So ideally, the fetal head is in line with the spine, shouldn't be flexed, shouldn't be extended. The nuchal region is clearly visible and not compressed or stretched. So why this matters is flexion underestimates NT and extension overestimates it. So inaccurate measurement can lead to inaccurate risk assessment for chromosomal abnormalities that we've talked about. So an ideal NT image, which is this, should have all of these things I'm going to mention now. So one of them is the crown plane should be aligned and measurable. So fetal head and upper thorax should be in mid-sagittal section. So nuchal translucency space, which is the fluid at the back of the baby's neck, should be clearly visible. So tip of the nose and the rectangular shape of the palate should be visible. Nuchal membrane, so separating, you have to, the nuchal membrane should be visualized separately from the amniotic membrane. Like I mentioned earlier, you can actually mess this up if you're not careful. So the simple trick there is to poke the tummy a little bit, poke the baby a little bit, and you can see the baby move. When the baby moves and the amnion doesn't move, so you can really tell that, yeah, this is the amnion and this is the, this is the part of the baby, which is the NT. So next up is the fetus should occupy at least 75% of the screen. So like I said earlier, zooming in, you're going to get less measurement error than when you measure in a very tiny image. So we don't need color Doppler, obviously not. So that is that for that. So we'll go to the next slide. So I'm going to be talking you through about the anatomy of what we should be looking at in trying to get the NT measurement and the CRL as well. So the CRL, yes, you if you're able to get it, all of these, that's fine, that's fantastic. But if you're not able to get it, you should be able to get all of these in the NT measurement. But ideally, you should be able to get everything, both in the NT measurement and in the CRL. So if you look at the midline structure, so number one, that is the midline structure. It runs all the way down and it's relatively hypoechoic. Number two is the mesencephalon. So that's a part of baby's brain, and it's also hypoechoic. But number three, which is the cerebellum, is relatively hyperechoic. So in relation to number two, number three, which is the cerebellum, is relatively hyperechoic to the mesencephalon. And number six there, of course, bone, it's bright, so that's hyperechoic. So it's going to be hyperechoic on your image. And the cisterna magna and the fourth ventricle, it's going to be definitely hypoechoic. So I'll see you in the next slide. I'll show you in the next slide what the image looks like. So I'll take all of this labeling off to make it a bit clearer. So this is a typical image of what I showed you in the last slide, but this is without the labeling. So we can see the midline structure there, which is completely hypoechoic, runs all the way down, and we can see the mesencephalon there as well. And we can also see the NT measurement really clearly on there. So inner to inner measurement. And remember, there's a posterior area there that looks hyperechoic as well that mimics the NT. So make sure that is not the NT. Like I said earlier, poke the tummy a little bit more, and you can see, you're going to see the baby move a little bit. So the baby is going to move independently from that amnion, and you can differentiate them and know that that is actually the NT. So yeah, that is that for that. So we're going to move on to the next one. So the next component of the combined screening test involves maternal serum biochemistry, specifically free beta human chorionic gonadotropin, which is beta HCG, and pregnancy associated plasma protein, which I called earlier as PAP-A. So both of these markers fluctuate predictably with gestational age and are influenced by chromosomal abnormalities. So free beta HCG is often elevated in pregnancies affected by trisomy 21. So PAP-A levels tend to be lower than average in pregnancies affected by chromosome trisomy 21, trisomy 18, and trisomy 13 as well. So blood samples, basically, it's collected from, let's say, it's from 10 weeks. So ideally from 10 weeks to 14 weeks in a day. So this is timed close to the ultrasound to get the most accuracy. So levels are then converted into multiples of median and adjusted for factors such as maternal weight, ethnicity, smoking status, and IVF pregnancy where applicable. So with the NT measurement, biochemical marker levels and maternal factors all impute into the screening software. A risk calculation is produced for each of these three trisomies. This results in a numerical probability, typically presented as something like 1 in 500 or 1 in 30. The result of 1 in 150 or greater is classified as high risk. The result of less than 1 in 150 is deemed low risk. It is crucial to understand and to explain to patients that this is not a diagnosis. It is an estimate of likelihood, so not a definitive answer. For patients in the high-risk group, diagnostic options are made available. So like I said earlier, if a screening result returns as high risk, patients are offered invasive diagnostic testing. So two primary options are available. So chorionic venous sampling, typically performed within 11 weeks. 11 and to 14 weeks, it involves obtaining placenta tissue via the abdomen or the cervix. The second one is amniocentesis, which is performed after 15 weeks and involves sampling the amniotic fluid. Both tests offer definitive genetic diagnosis, detecting chromosomal and some single gene disorders. However, they are invasive and carry small risks of miscarriage, approximately 0.1 to 0.5%, depending on local practice. So the thing is, it's quite hard at this stage because we had to cancel before and after this test. So it has to be very clear. We have to be very clear with the outcomes and everything, with statistics as well. And, we have to be compassionate as well because this is an invasive procedure. And it's essential for patients to understand their choices as well and feel supported regardless of their decision. In cases where combined test is impossible, often due to late presentation or clinical issues or technical limitations, so the quadruple test can be offered between 14 weeks and 2 days to about 20 weeks, but typically we do it at about 16 weeks, which is still fine. So this test uses 4 maternal serum markers, so alpha fetoprotein, so what we call AFP, total HCG, and unconjugated estrol, inhibin A as well. So these are 4 of them that we normally use. So the quadruple test, however, only screens for trisomy 21 and is notably less sensitive than the combined screening. That's why it's offered as a second option, not as a first line of action. So it is important for clinicians and patients alike to understand the detection rates and false positive rates of screening. Combined screening detects 85 to 90% of trisomy 21 cases with a false positive rate of around 2%, which is very good. And the quadruple test has a lower sensitivity of around 75% and a false positive rate of 3% or more, which is still not too bad. So these statistics reinforce why performing high quality, correctly timed combined screening is very valuable. It not only improves detection, but also reduces unnecessary testing. So I'm going to conclude by saying, first trimester combined screening, it's a cornerstone of modern antenatal care, allowing us to detect early and effectively pregnancies at higher risk of significant chromosomal abnormalities. But this test is only as strong as the accuracy of our ultrasound technique, the quality of our communication, and also commitment to patient-centered care. By adhering to national guidelines and clinical best practices, we can ensure that expectant families are given the information, clarity, and emotional support they need to make an empowered decision about their care. Thank you for joining me on this section. Once again, I am Stanley, Advanced Practitioner Sonographer with the NHS England, and it has been a privilege to walk you through this vital topic. Thank you.